Gonna wait about another minute or so. Okay, so we're gonna get started and pick up where we left off yesterday with our last disease on the first presentation, which was ARDS. Let's see here. Okay, so ARDS, no statistics were quoted here, but we did talk about the mortality rates in another course, previous topic. And over the years, this has not really been getting much better as far as the outcomes. Most hospitals are still experiencing somewhere around 40% mortality rate and 30 to 40%. And even though we're doing the protective lung strategies, we're using the smaller tidal volumes and we're doing all these other things to try to minimize the damage. But because of the nature of the process, it's still hard to manage these patients once they do reach this state. And we just keep working at it, and maybe in a few more years, maybe the mortality rates will start to show some improvement. So what we're looking at is definitely a serious case of refractory hypoxemia. And not only is there refractory hypoxemia, but there's also ventilation problems. So the lungs are essentially, they're shot. And this is a multi-system problem, which is why it's so complicated. And once it does develop, you've got to treat all of the failing systems. And while they're on the ventilator, we're trying to tend to, of course, the oxygenation and ventilation, but then what about all of the other organs? So what happens is it's usually some kind of lung injury. And there are many different things that can lead to lung injury, but these are going to be like more the common things, like they got a really bad infection and that infection got worse and it took over and they became septic, or maybe they were inhaling something and that was considered to be toxic, and then that changed the lungs as far as the alveoli, and the body went into an immune response, and then it just kind of like spiraled from there. Pneumonia could be one of the precipitating factors. And then just your obvious, like someone was in a really bad car accident. And while you're trying to to support them on the ventilator, they may still end up going into ARDS despite all of your efforts because of just the nature of their injury. And then these other things, and of course, this is not the complete list. There's so many other things that will all end up causing so much harm that they'll probably end up developing ARDS. And we've got things like pancreatitis, for instance, and even patients who've had bypass surgery, cardiac bypass surgery, they are always at risk and they have to be monitored very carefully. Anybody who has to get multiple blood transfusions, they're definitely at a high risk as well. Your burn victims, burn by itself is a problem. And we'll talk a little bit about burn and injuries in the next presentation in just a little while. O2 toxicity, they feel that all those free radicals, if you give someone too much oxygen, what do we say, more than 60%, over more than like a 24-hour period, you build up all of these extra, they call free radicals of oxygen in the body, and that starts to change the membranes as far as the alveolar membranes and the pulmonary capillary membranes. They're changing. They're allowing things to now leave that shouldn't be leaving, and then it just kind of goes from there. So now the pathophysiology, it looks like there's a lot going on, but really this is just a heightened immune response that we're focusing on with the lungs. But just keep in mind that all the other organs are experiencing the same issue, more or less. So you start off with whatever your problem is, like maybe you were, again, some kind of trauma and really bad chest trauma, or you near drowning victim, or you got exposed to something, and then of course your body goes into its normal routine as far as whenever there's some kind of injury. The first thing that you'd expect to happen with injury is inflammation. So you got these cytokines that are going to be released, and these other, they call them pro-inflammatory molecules. And then once those cytokines are released, then that's going to trigger definitely more of an immune response. You're going to have now your white blood cells in full capacity. And then you've got certain cells that are usually called like the mast cells, MAST cells. They're the ones that are going to be holding on to a lot of these different mediators that when released, it's going to create even more of like an immune response. So like leukotrienes, for instance, there's something that these mast cells will be releasing when they need to. And it usually is, again, it's some kind of allergic response that's triggering this. And then not only are these leukotrienes and other things being released, but then these like platelet activating factors are going to be released. So now, again, this is all expected, but it's at a heightened level, which is not going to work out for the lungs. Because what's going to end up happening is all these mediators are going to end up literally just destroying your alveolar membrane. And if the alveolar membrane is now destroyed, that means that it's going to absorb any and everything. All of the fluid that's out there, all the interstitial fluid is going to be absorbed. And the pulmonary capillaries, their membrane is also being destroyed. So they're leaking. So a lot of times people are going to refer to ARDS as leaky capillaries. And as the capillaries are leaking, these alveoli are literally just absorbing all of that fluid. So that's the increased permeability problem. And once that happens, now you're definitely going to see some swelling. So there's going to be a lot of edema, and then there's going to be some bleeding involved with that as well. And then that in itself is going to trigger another response. And it's just going to keep just building on itself. And we know that anytime that you've got more water inside of the alveoli, there's only so much your surfactant can do. If you have way more water, that water is either going to wash out your surfactant or it's just going to inactivate it. So we're going to say that once this extra fluid and all this swelling is going on, your surfactant is literally just not even working anymore. And without surfactant, we know how difficult it's going to be to get those alveoli to open up and expand. So on the ventilator, this is the tricky part. So you've got someone who's developed ARDS, and your goal is not to create any more damage if possible. So they're always at risk of barotrauma when they're in this state. So then you got to think, what's going to happen if on the ventilator, each time that they get a breath delivered, because the surfactant is not really working, what is it going to take to get those alveoli to open up so that the volume can be delivered? It'll usually take a lot. We could, we had the time, we could really talk more about they call it hysteresis that you expect to see when you're looking at the pressure volume loop on the ventilator graphics. And from that pressure volume loop, you can kind of see that critical opening moment as far as when the alveoli are finally opening up. They call it, in another chapter, when we were looking at the waveforms chapter, they call it the lower inflection point, or LIP. It's that lower inflection point is where you should be targeting like your PEEP. You don't want your alveoli to keep collapsing. You don't want them to open up when the ventilator is delivering the breath, and then when the patient is exhaling, you don't want the alveoli to go completely back to collapse, because if you do, the next breath is going to take a lot more effort again to get them to open up. So you kind of think of it as atelectrauma, which is just if you took like a thin piece of metal and you pretend that your alveoli are this really thin piece of metal, and you're bending this metal back and forth, and that would be the equivalent of the alveoli being forced open and then collapsing again with each breath. So you keep bending this metal back and forth, it's just going to be a matter of time before it breaks. And that's what will end up happening if you can't find a way to keep the alveoli from collapsing. So PEEP is important for that reason, so that you try not to allow these alveoli to go back to a collapsed state. So then here we are as things get worse. Then, because again, this is an immune response, your alveolar walls are going to get really thick. And what's happening is you got all this stuff that's just building up. All these mediators were activated. You got these platelet activating factors, and it's kind of like, think of it almost like scabbing. You're gonna have all this like extra thick stuff, and then over time, even your type 2 cells are going to be affected. So the surfactant that they're producing is already not really going to be working. And then on top of that, now with all of this extended damage, they're just not going to be able to function like they're supposed to. And then it just keeps going from there. So you got more of this stuff that's just building up inside of the alveoli. And that's the fibrotic part about it. So ARDS is a pulmonary restrictive lung disorder by nature because of what's happening. And until you can find a way to overcome this, I mean, as far as you're treating the patient, until you can find a way to overcome that and help them to oxygenate and ventilate, it's going to be an uphill battle. Now this picture is not very clear. It's a little blurry, but I included it here just to kind of give you like a visual of what's happening. So we had everything written out on the previous slide, but this is just kind of a way that you can just follow like some of the major events that are going to happen. So it all starts with the injury, whatever it is that happened. You inhaled, you were near drown victim, or whatever the case is, and then it just starts from there. Again, it's an immune response, and then we can just kind of see, if you follow the arrows, what's expected to happen. So really, ARDS is a lot of things, but it's still, they used to call it like an acute lung injury, but it's really more than just an acute lung injury. The ALI is usually what precipitates the ARDS. And then over on the right, this is just a visual of kind of showing what's happening. Like once your white blood cells are now fully active and everything is being released, and then your surfactant is now being deactivated, and then it just kind of spirals from there. And then you got the buildup of all of the, got the platelet activating factors, and then you got all the fibrin, and then the walls of the alveoli, they're letting anything in that shouldn't be going in. All the fluid is now crossing over. Capillaries are leaking, and then at the same time, the walls are getting thicker over time as well. So it makes it extremely, extremely challenging to manage these patients, extremely challenging. And there's really no drugs that you could give to treat ARDS per se. Your efforts are all supportive, and you're trying to maintain the best oxygenation that you can. And you're a lot of times happy with a PaO2 of 50. You get a PaO2 of 50 with some of these patients, you're usually celebrating. And then everything else, like hemodynamically, you're trying to keep them, you're trying to support them. And also, like as far as fluid balance, then you got to keep a really close eye on that as well. Okay. So I said yesterday, I mean, once we got hit with the COVID, all the hospitals were like, wow, they didn't expect COVID to have this kind of response. And most of these patients who ended up in really bad shape ended up in ARDS. So really they're having to treat COVID for the ICU patients just like they do ARDS, so that whatever their protocols are, they're doing the exact same protocols, which would mean using the ARDSnet guideline, the tidal volumes and the PEEP and that sort of thing. All right, so the signs and symptoms that you'd expect. Now, ARDS isn't something that you'd expect to happen like an acutely kind of thing. It usually takes a little bit of time. So, they'll probably start complaining of being short of breath. And then as it gets worse, you'd expect to see the things like, well, the altered level of consciousness, that may happen or it may not happen. And the reason I say that is because I remember a coworker who was telling me about a young patient that they admitted to her hospital, and she was maybe early 20s and healthy, but she had she had taken a trip somewhere. I forget where they said she went. She went out of the country somewhere, and when she came back, she felt a little bit not right. So she didn't have many of these symptoms here at all. She just kind of felt, just didn't feel that good. And she just kind of attributed it to jet lag. And so she didn't really look into it and didn't go to see anybody. And then she got a little bit worse. So then I think she became a little bit more concerned that something's just not right. And so by the time that she did go to the hospital, they were like, we're going to have to observe you. And they admitted her to the floor. And then once she got admitted, my coworker was saying that it didn't take but like maybe a day and she just went downhill rapidly. And so they had to end up, of course, transferring her to the ICU. She had to get intubated. They placed her on the ventilator. And from there, she just got really, really bad. So she ended up in full-blown ARDS. And so it's just like, it says one of those things where you just never know. She must have got exposed to something wherever she was and kind of downplayed the symptoms that she had in the beginning. So of course the refractory hypoxemia, that's always our biggest challenge. Like, how are you going to oxygenate when the lungs are that bad? And then the last point here, when you're using using your ventilator, in volume control, you can't control your peak pressures. So if you're not careful, you are going to make matters worse by creating more or more of a risk of barotrauma. So you most likely would have to use some form of pressure control, whether it's just pressure control ventilation or if it's APRV, which will work a whole lot better than just regular pressure control. So then when they finally do diagnose a patient of having ARDS, they're looking at multiple things, of course. So physical, the x-rays, possibly CT. And then the ABGs, as you see, the ABGs are kind of the same for most of these lung problems. You're going to end up in distress, so you expect alkalosis when you're tachypnic. And in really, really bad cases, you expect type 2 failure because of the CO2 problem. Now, the X-ray, they use the word ground glass, so that's our key word there. And we saw pictures of what ground glass is supposed to represent, and it's just the glass that you can't really see through that clearly. You see a shadow and you see an image, but you can't really make it out too clearly. And if they don't use the word ground glass, they're going to use reticulogranular or reticulogranular process or nodules or something like that. But it all kind of means the same thing. Increased opacity, more white. So radiopaque is what we expect to see with this kind of problem. Now remember, ARDS is a non-cardiogenic type of pulmonary edema. So this is all we expect to see a lot of white, which will represent the fluid. And nothing is really good about this X-ray. I can't make one good comment about it, really. I mean, there's a little bit of aeration going on in the upper lobes, but not that much. And this patient is obviously intubated. If you can follow, you can see that here's the radiopaque line of the ET tube. And we wouldn't expect there to be in a large heart because this is a non-cardiogenic type of pulmonary edema. So the heart overall looks to be appropriate size. And I can't really say anything good about this picture. All I can say is a good thing that the patient is already intubated, because if you saw an X-ray like this and he or she wasn't already intubated, then what are you waiting for? Now, how do you treat? Again, this is just all supportive. You're going to try to do the best you can at targeting a saturation greater than 90. Again, you'll be lucky in some cases even getting right close to 90% saturation. And then, of course, you're going to have to do your ARDSNet guidelines and try to keep your tidal volumes, 4 to 6 milliliters per kg, and or 6 to 8 milliliters per kg, and you may have to go as low as 4 in some cases, and higher respiratory rates to try to offset the fact that you're using such small tidal volumes, because it still comes down to tidal volume and respiratory rate equals minute ventilation. You still got to try to ventilate them as best as possible. And if you are using really, really small tidal volumes, there's only so much you can do with your respiratory rate. If you turn your respiratory rate up to 20, then that still may not be enough. If you turn it up to 30, then that's going to create problems because they're not going to have enough time to exhale. But that's kind of not their biggest concern at that point. So what they'll usually end up doing is they'll just do the permissive hypercapnia. So it wasn't mentioned here, but I'm just going to write out to the side that in most cases, the physician will just have to write in the chart that it's okay for CO2s to be greater than 50. Or they may write like maintain CO2 less than 60. So that gives you the permission to allow the CO2s to be elevated, permissive hypercapnia. Now, prone positioning, this is something that does have a lot of benefits. If you go through all the trouble of positioning these patients on their bellies, that'll give the lower lobes in the back, the posterior lower lobes, that'll give them a chance to be recruited. The alveoli should get a chance to recruit. So you're using gravity to your advantage with the prone positioning. It's just a lot of effort if you got someone who's connected to 1,000,001 IVs and everything else. And it just takes a lot of people to do it. And it's usually like a cycle. You'll keep them in a prone position for X amount of hours, and then you go back and you flip them back in the supine position for another so many hours, and then just kind of keep that schedule going. And if you do it right, you usually will see your saturations improve once you do place them in a prone position. And then, of course, antibiotics, steroids, because this is a full-blown immune response. So you're going to a lot of times have to give them a lot of steroids. And then the fluid balance thing. So that's something they definitely have to manage. So those I's and O's are going to be monitored very closely for someone with ARDS. It used to be that the NBRC would not want you to recommend diuretics for someone who had ARDS, like in your clinical simulations, but that's not the concern anymore. I mean, it's like you've got to make sure that you are dealing with all this extra fluid. So I guess their rationale used to be back in the day is that if you're not careful, you may diurese too much, and then that's just going to compound all their other problems. But whatever it takes to maintain adequate balance, because you got to still give them fluids, but you don't want to, of course, give them too much because they're already retaining a lot of fluid. Now, which is not a common cause for a pulmonary embolus? Hypercoagulability. This means that you have someone who clots very, very fast and very easily, and possibly they clot way too much. That would be like at one of the top of the list. So we're looking for 3 of these are going to be potential causes for PE, but one of these is not necessarily going to lead to a PE. But I would say out of all of these would be at the top of the list of causing PE. Yes, it's the C. So if you've got all this, you've got all this fluid that's in your belly and your peritoneal cavity or abdominal cavity. If you've got all this extra fluid, you're at risk of having maybe a pleural effusion, but not a pulmonary embolus. A pulmonary embolus is for simplicity. We're going to say there's some kind of clot that's now stuck in your pulmonary artery. And the source of that clot, usually, blood or, maybe some tissue, like in a case of like a tumor, a part of a tumor broke off and now it's stuck in your pulmonary artery. The venous stasis is just, the people who've got blood that are that's pooling down in their legs. I mean, people who have like, varicose veins, they're usually at a great risk of this as well. So that's what the venous stasis is. And again, the hypercoagulability, that's somebody who, if they aren't getting blood thinners on a routine basis, they better be taking at least a baby aspirin every day. Okay. A possible cause for cardiogenic pulmonary edema. Yes, this is heart related. So all these others, the altitude, drug overdose, septicemia, those are things that will lead to pulmonary edema, but it's not heart related. It's, non-cardiogenic. Any of the following could help differentiate right main stem intubation from a tension pneumo, except. So for both of these issues, what can help you distinguish one from the other? Oh, which one of these cannot help you? What's that? Oh, any can help. Okay, so am I reading this correctly? So they kind of look the same. They present the same way. All right, so let's see how this question could be maybe reworded. Okay, so what this is saying is that if your ET tube is in the right main stem bronchus, you'd expect the peak pressures to go up. If you had a tension pneumothorax, it's the same thing. You would expect that the peak pressures would go up. So that's not going to be helpful. So in other words, you're trying to decide between, is this really pneumothorax? Because they both look almost the same on X-ray. You can see the increased the air, which will be radiolucent or hyperlucency. They both look that way, and then breath sounds are pretty much about the same. You may not hear anything on the affected side. And if you did let me just start with the B here. If you did your diagnostic percussion where you're tapping on the chest with your finger, because of the air trapping situation in both, you're going to hear the same hyper resonant note here. So this question is weird. Hyper resonant. Yeah, it's a weird question. Tracheal deviation. You would not expect the trachea to deviate if it's in the right main stem bronchus, but with a tension pneumothorax, you would expect it to deviate. And then with the chest X-ray, you should be able to see the ET tube placement. If the ET tube looks like it is literally in the right bronchus, and of course everything is really dark on that side, then that would definitely mean that you got to pull the ET tube back. It's in the right main stem bronchus. It's not a pneumothorax. So that would be helpful. The X-ray could help so you could really see what's going on with the ET tube placement. And again, the tracheal palpation, that is going to be something that you would expect the trachea to be shifting when there's just the ET tube in the right main stem bronchus. And then diagnostic percussion, they both are going to give you a hyperresonant no, really, because they're both air trapping. And they both will end up causing higher peak pressures. So either way, let's just scrap this question. And at least, we understand that we have to be careful with these two problems because they can kind of look the same, but you have to drill down further and see what it is that will make the difference between one and the other. And what will make the difference between one and the other is if you can see where your ET tube placement is, and if you notice whether or not there's any tracheal deviation. Okay, so what is renal disease? Renal disease to hemodialysis as what is to plasmapheresis? So we just have an analogy here. Okay, so right, the best therapy for myasthenia is definitely clean out their blood plasma, get those antibodies out. Same will go for Guillain-Barré. You can get them in a plasmapheresis, then they usually do a whole lot better. Is this true or false? So you say true, but this is a tricky question because if you only looked at this right here, if you say that IS can be useful for treating pneumonia, then that would definitely be true because that's something that you expect them to do is work really hard on their sinus barometer to try to treat any atelectasis and also to reverse any atelectasis that they may have already developed. But this is saying that a patient has developed a pleural effusion that's secondary to the pneumonia, meaning that, of course, they have the pneumonia, and now they got this problem here. They got this fluid in the pleural space. IS is not going to treat. It's not going to help this pleural effusion. So it's just one of those questions where you have to just read very carefully and step back from the question if you have to and just kind of look at it and say, what is it that we're trying to get at here? And so again, the treatment for pleural effusion would be, if it's a small one, they could just do a thoracentesis and evacuate out the fluid that way. And if it's a large one or it's going to keep coming back, then they're going to have to use a chest tube and drain it. Now, physiologic changes that are expected in ARDS, multi-organ failure, and okay, the edema. Now, had this said decreased PF ratio, then that would have also been a possible answer. And remember your PF ratio, we're going to use, well, again, the book is still using an old standard. So anything less than 200 is considered to be ARDS based on the older standards. And an increased ratio is actually good. That's what you'd expect. You expect a really high ratio, like 400 if you're healthy, 500. And if this said thickening of the AC membrane, then that would have been something you'd expect because of all the, again, the platelets and the fibrin and everything's just kind of like building up and it's just creating this really, really thick kind of like layer in the alveoli. And then had this said increased shunt, then that's their refractory hypoxemia situation. No matter how much oxygen you give them, they're just not really going to respond to that oxygen because of this huge, huge VQ mismatch situation that's going on. Okay. Any of these can cause or lead to ARDS, except yeah, just because you're breathing dry air does not necessarily mean you're going to end up injuring your lungs. So all these other things here, in some way, they're going to lead to a lung injury. And then it goes from there. Okay, so that's the first group of restrictive disorders. So we had the neuromuscular weakness category. That was the Guillain-Barré, myasthenia gravis. And then all the others were pulmonary restrictive disorders. And that was the PE, the pulmonary edema, the pneumonia, the ARDS. Am I missing anything? All right, so now let's just continue with, where is the next one? Here it is. So now we got a few more restrictive diseases to compare with the others. Okay, so for these last group of diseases, it's just the same. We're going to talk about what you expect to find when you're doing your evaluation or assessment, and then we'll look at, you know, how it happens, you know, what's expected to cause this problem, and then what options do we have for treatment, if there are any options for treatment. Now, for your thought, this is your very last your thought. So I'm looking for everybody to hit this one out of the park. This is a multiple. There may be more than one answer you can choose from here. Okay, looks like you're thinking this, and you're mostly thinking this and this. Now, you look at what's going on. You got a burn victim, fully paralyzed and sedated, and this is your ABG that you get. So when you get your ABG, the first thing you always look at is your pH. And so with that pH being acidic, we see that whatever our vent settings are right now, it's not enough because there's a ventilatory problem. And we're controlling everything. This is someone who's not doing anything. They're completely sedated and paralyzed. So this is on you and your settings. So you have to look for options to address this pH problem. And that means that if we just kind of go down the list here, the FiO2 is something that you can definitely improve. You can say that, this is something that we would need to address. It's not terrible right now. It's a PO2 of 62 and a saturation of 91%. So for ventilated patients, we're not always just looking for like 80 to 100. I mean, we get them at 60, then that's usually good. That's a good place to be. And it all comes down to the pH. And we know that if the pH is abnormal, all of your cellular activities that are supposed to be happening, all your metabolic processes that are going on in the body, they're not going to be working correctly. Any medications that are being given, they're not going to be working because of the abnormal pH. So you have to maintain a homeostasis. You have to have a normal pH range for everything to work the way it's supposed to, and the patient is supposed to be getting better. So that's why we're not going to really focus on this, because it doesn't seem to be a problem yet. It's all about this pH right now. That's what it's all about. So then we go to the number 2. Yes, whatever your delta P is in your pressure control setting, let's say your delta P is 20, you're going to need to go up, because if you go up on your delta P, then you get more tidal volume. You get more volume, and then that would mean more minute ventilation. And that would help to deal with this pH problem. Well, it's the CO2 problem that's causing the pH to be acidic. And then we say decrease the expiratory time. That won't have anything to do with ventilation. Decreasing your E time is going to mean that you're doing like an inverse ratio kind of situation, or you're trying to head toward inverse ratio where you want a longer I time and a shorter E time. And again, that's something that would be useful for oxygenation, increasing mean area pressure, but it's not going to impact your ventilation. And that's still our focus here. And of course, it's all about minute ventilation. So these two right here, they're going to increase your minute ventilation. Or frequency. So we're looking at, that's our tidal volume. I mean, that's our respiratory rate. And then this is going to be indirectly controlling your tidal volume. And the more minute ventilation that you get, the less the CO2 would be, or less the CO2 should be. And then you get less CO2 and your pH should go back up. Okay. All right, now this is the end results here, where pretty much everybody recognized that you got to turn up the frequency. You got to increase the respiratory rate if that's your goal, is to get your CO2 to go down. And then the pressure limit was the one, I think, that threw most people off, because you got to think of this as your tidal volume when you're in pressure control. Okay. All right. So let's go ahead and talk about pneumoconiosis. Now, I just added this in here. This is not necessary. That's why I didn't even think about adding it to your to the slides before I uploaded them. I literally just did this before class started, because this is something that if you ask people, like in the English dictionary, like what's the longest word that there is, and most people will say, well, it's a supercalifragilistic something that nonsense gibberish or whatever. It isn't. This is the longest word that's in the English dictionary. It's Pneumono ultra microscopy silico volcanonokel. So in other words, this is a type of pneumocanosis. And a pneumocanosis is a form of an interstitial lung disease. So all of the interstitial lung diseases that are out there, there's known as ILDs for short. ILDs are the umbrella. And then underneath them are going to be these different types of diseases like the pneumoconoses. And then under the pneumoconoses, then there's these other specific types of pneumoconoses. So it starts with that, and then you've got your pneumoconoses. And then from there, there's really just three main types of pneumocanosis or noses. You've got asbestosis, and then you've got silicosis, and then you've got, let's just call it black lung disease or coal miner's lung. So now, this pneumonoculture, that's just another way of saying silicosis. If you notice, there's silicosis right there, at least part of it. Now, your ILDs, being that they're just like an umbrella, like you've got a lot of different type of problems that can lead to your lungs getting really like fibrotic. So think like pulmonary fibrosis. If you don't want to say ILD, you're just probably going to say pulmonary fibrosis anyway. But from there, if you're working in some kind of environment where you're inhaling something that is inorganic and it's affecting your lungs, over time, you're going to end up with problems. And that could lead to a very fibrotic type of lung. And there's going to be some oxygen diffusion problems. And there's going to be problems with trying to take deep breath because you're going to have all of this, like this is the restrictive problem. So you're going to have a really hard time with volumes and capacities. So this is a list of some of the things. There's so many things that can lead to a pneumocanosis. Again, the silica, that's the silicosis. Silica is your sand. So like the picture that I included here, this guy is using a sand blaster. So if you are inhaling the fine particles of sand over time, it's going to, your body goes into, it's like an immune response. There's something in here that's foreign, and there's going to be some swelling, and then after the swelling is over, there's going to be some healing. And anytime tissue heals, it leaves behind a scar, or there's going to be scar tissue. And then this process will just keep happening over and over again. And it usually takes a while. They say if you've been in a kind of environment where you've been inhaling something that's not good for your lungs, if you've been doing it for like 20 years or so, then you're going to probably end up with a really bad case of pneumocanosis. And then the physician will just diagnose you as having, based on what it is that you've been inhaling for all those years. So like in the case of this guy who's doing sandblasting, he would end up with silicosis. Or in the case of someone who's working in a mine, mining for coal, then they would end up with coal miner's lung. And same goes with asbestosis or berylliosis, et cetera, et cetera. Talcosis. Talcosis is something that you'd have to ask yourself, who in the world would end up with that kind of a problem? Now, talc is just your standard, like your baby powder, like any powder that you use to put on your body to absorb moisture and decrease friction and that sort of thing. Now, who do you think? What profession do you feel could end up with a really bad case of talcosis? So I see gymnasts. Now, those gymnasts, they do have to use a lot of talc powder when they're trying when they're before they do like some kind of bar. They got to be grabbing onto a bar or something. So let's say you have a gymnast who has been doing this for years, and as they're putting all this talc on their hands, and it's just creating like a powder, a puff of powder that's in the air temporarily, and then you're inhaling this into your lungs. So that's somebody who would be definitely at risk. Anybody else you can think of who may be exposed to talc powder over a long time? Powder factory operators. Okay, if you're on the line, if you're on the manufacturing line, and you're dealing with this, then and you're not wearing a mask, then you're for sure possibly going to end up with something like this. And then think about somebody else. Think about somebody who maybe works in healthcare. A chemist. Uh, Now, a chemist, as I'm looking at these others, like the beryllium, like some chemical, like that nature, that it's maybe like aerosolizing in the air and they're inhaling it possibly. But I don't really see them working with talc unless they were just doing specific stuff with just talc. So let's take our 10-minute break. And then after the 10-minute break, maybe you had a chance to kind of think a little bit more about it. Who do you think maybe like a healthcare worker who would probably be at risk of talcosis? Okay, we're back. Now, I see some activity in your individual breakout groups. So, was that intended for the group chat, or was that just still within your group that you were trying to communicate? All right, now, I see engineers, see EMS. Yeah, these are definitely all bad if you're going to be exposed to these types of substances over time, and it's going to cause some structural changes to the lungs. So I was just trying to expand a little bit on the talcosis because in the nursing department, most times they're going to use this talc powder on the patient's sheets to try to avoid or try to at least minimize the skin breakdown, the decubitus ulcers, because the talc will create like a almost like a frictionless surface where as they're sliding around on the sheets, it's not necessarily going to be wearing down the skin. And then at the same time, the talc is going to be absorbent, so that's going to help to wick away some of that extra moisture. So if they're preparing the beds like that often, all the time before the patient gets there, yeah, the niacin, right? Yeah, so the nystatin or the just a regular talc powder, because the places that I work, they always just use regular talc powder, and they would just literally just pour all this powder on the sheets, and then in the room there's just this big cloud of powder. And I'm thinking to myself, wow, if you're breathing that stuff in all the time, and again, about somewhere around 20 years, if you're doing that, then you could be definitely at risk of like the talcosis. I read a story or an article in some journal a while ago where there were some physicians in India. They were stumped. They were trying to figure out how in the world there was a very young patient. She was really, really young, like maybe not even quite 20 yet. And she ended up with a really bad case of pneumocinosis. So then finally somebody asked the right question. They asked, like, what was her daily routine? What did she do each day? So she said ever since she was like a really, really small girl, she would, of course, take a bath in the morning. And then after the bath, and she dries herself off, she would just take like some kind of fragrant powder and just literally just douse herself from head to toe with this. And she'd been doing that every day since she was a little girl. And then over the years, she ended up, not being able to breathe. She's got a really, really bad case of pneumocinosis. And so once you get it, there's no going back, unfortunately. So let me just rewrite what I did up here because it's a little crowded because I wanted to add a couple more things anyway. So let me just write ILD and then just kind of add a few more things. I mentioned that some people are going to just say that pulmonary fibrosis is an IL is ILD, but really being that this is just kind of like a big blanket statement or big blanket category or like an umbrella kind of statement. Let's add, we have the pneumocinosis, and then we have the silicosis. I'm sorry, then we have the pulmonary fibrosis. And then we have what's called BOOP, which just stands for bronchiolitis obliterans pneumonia, organizing pneumonia. Bronchiolitis obliterans organizing pneumonia. This is like a pneumonitis. it kind of looks like pneumonia with as far as the signs and the symptoms, but it doesn't respond to antibiotics or any of the other traditional treatments that you give for pneumonia. This is because it's an itis, it's going to require steroids. So a lot of times they can't diagnose a patient with BOOP right away because it looks too much like pneumonia. X-rays look like pneumonia, everything looks like pneumonia. So they have to start off with, let's just treat it as pneumonia. If they don't get better after about a couple of weeks, then they'll know that they're dealing with a BOOP instead of an actual pneumonia. I think in Europe they call it COP for short, cryptogenic organizing pneumonia, but it's the same thing. And then also, this is given the nickname popcorn lung. AKA popcorn lung. And there's a story behind that if you haven't already heard about it. Now, the popcorn lung thing came about when, I forget exactly the year that it happened, but there was a guy, he was a professional opera singer, and at some point, he was having a hard time singing. He couldn't take a deep enough breath to hold the notes and do what else he needed to do. So then he started, of course, go to his physician, and he found out that he ended up with a restrictive lung disease, and they were trying to, of course, figure out what happened. And so he was one of those people who ate microwave popcorn every day and 2 times a day or more in some cases. And the first thing that he would do before he started to eat the popcorn after he gets out of the microwave, he would open up the bag, he said, and he would just take a really deep breath. He'd just take a really deep smell of the that artificial butter that they were using on the popcorn. That artificial butter, which is known as diacetyl. Artificial butter agent. Used on microwave popcorn. So it was that diacetyl that was damaging his lungs, and he was doing this every day, like 2 times or more a day, for maybe like almost close to 20 years or so. That's what got him. And because he couldn't even like sing anymore, which is his actual livelihood in his career, he definitely qualified for disability. But he wasn't happy with just going on disability. He sued the company, the microwave popcorn company, for a crazy amount of money, and he won. And then after that, it was like, I forget how many millions that he won in damages. But after that, they did a little bit more investigating, and come to find out, people who worked at that manufacturing company that actually made the popcorn, they were also having the same problems, and they were being exposed to this diacetyl. So they did I think they did like a class action suit, and they won millions. So then I remember going to the supermarket and looking at boxes of popcorn, and some of them were definitely proudly advertising that they weren't using diacetyl, so no diacetyl in their ingredients anymore. So they were using some other kind of artificial agent, and I don't think that's doing you any good either. So the moral of that story is, if you want butter on your popcorn, use real butter. So that's the whole thing. If you wanted to look into it, all you have to do is just like Google popcorn lung, and then this is what it is. It's a type of BOOP is what it ends up being. Again, once the damage is there, you can't reverse it. You can't go back to healthy lung tissue. It's too fibrotic, and it's too restricted now. And you're going to have a hard time with oxygen diffusing into your blood. So we got pneumocanosis, pulmonary fibrosis, BOOP for ILDs, and then from the pneumocanosis, the three major ones, even though again, you see there's so many different things that you could be inhaling and it would cause a type of pneumocanosis, but the main three that most people are going to identify would be the asbestos, the silicosis, and then the black lung or coal miner's lung. And then before we move on, we of course know that this is occupational hazard, sandblasting. You're using sand to break through like concrete. And anybody who makes computer chips, like you have companies that's all they do is just make computer chips that go into your computers and all electronics that need some kind of circuit board. The silicone that's being used in those chips, that's sand essentially. So if it's being grinded, if you're like grinding it down or doing something of that nature, it's possibly floating in the air. And that's somebody who would also, if they're not protecting themselves, they would be at risk of a pneumocanosis over time. All right. And so what happens is it really all depends. I mean, you can have some mild exposures and it's not necessarily going to be that problematic because when you think about all the mucus that's inside of your airways and your lungs, it will trap a lot of that stuff. And then you'll end up, the mucociliary escalator or ladder will end up getting it out and then you'll end up either like swallowing it without thinking about it or just end up coughing it out. But if it's something that's pretty substantial and you've, again, been exposed to this for years, then you may be in trouble. So then, even though we say this is a pulmonary restrictive problem, these ILDs are all going to be considered pulmonary restrictive. It can end up being like a mixed. And a lot of those like ILDs will show mixed, like sarcoidosis is one of those that would show as a mixed kind of problem. And to be mixed on your PFTs, the obvious pattern. Your FEV1, FVC is less than 70%, and your TLC is less than 80%. So that'd be like the most obvious when there's a mixed problem. So then what happens as far as the pathophysiology? So I always start with you're breathing in something that is foreign and is inorganic. And now your immunity system takes over. It recognizes that this is not natural, it's not native to the body. And then it's kind of like ARDS, when you think about all of your white blood cells that are now responding, and then all of these like mediators are going to be released, and then you're going to start to get some structural changes that's going on with your membranes, and then stuff is now leaking out, and then eventually all of this stuff starts to build up, all of this fibrin and all this other stuff, and then you end up with like really, really tough membrane, and that's the fibrosis that sets in over time. And depending on the exact problem, a lot of times they're going to describe the lung as almost like a honeycomb pattern. This is the cyst-like structures that they're talking about. So like in a lot of cases, like a pulmonary fibrosis, if you look at their x-ray, it looks almost like a honeycomb. And I think we have a picture and a few more slides that will show that. So as far as the symptoms, this looks to be distress, as we've seen with all the other lung problems, increased, tachy's, definitely shortness of breath, and more pronounced. This is going to be definitely more pronounced with activity, right? Especially with activity. So dyspnea on exertion, if they get up and start trying to do something, and they're going to be extremely short of breath. Now, a word about their respiratory rate. So with any of these restrictive lung diseases, if you can't take a deep enough breath, your body tries to compensate by just breathing faster. So they're breathing pretty shallow, but they're breathing really, really fast because it still comes down to minute ventilation. The cells need a certain amount of minute ventilation. Cyanosis and the digit clubbing, that's long-standing chronic hypoxemia because of the diffusion problem. So all of these ILDs, they're going to have some extreme issues with gas diffusion. So the DLCO on the PFT test, you'd expect it to be really low or abnormally low. Peripheral edema in a lot of cases, and then sometimes, and there's not always, but they may have a productive cough, but then a lot of times it may just be a dry cough. But it doesn't matter because, it's still going to be a cough regardless, as you have with all lung problems. And then diagnosis, of course, they will ask, what have you been doing for work for all these years? And then they go from there and look at x-rays, and then they will possibly maybe have you do a complete PFT to confirm that you definitely have a restrictive disorder, and there's also a diffusion problem on top of that. So now, what would you expect to see? So this x-ray, now we're not really going to be expected to look at this x-ray and not have much else to go off of. Meaning that if you were to look at this x-ray, you can see this it's abnormal. Like, this does not look normal by any means, but you wouldn't be expected to know exactly what the problem is. You can't say this is definitely silicosis or no, this is not silicosis, this is actually asbestosis, because they all kind of have the same kind of problem. So we're going to just generalize this and say that there's going to be a lot of white, these irregular opacities. Notice that it's not very consistent. Some of it looks a little bit bigger, like this is a pretty big patch of white. That's a bigger patch of white. That's a smaller little patch, so that's the irregularity that they're describing here. And on this particular x-ray, we can see the actual claustrophrenic angles. I mean, they're not the clearest because there's still a lot of white, but it may still be irregular, is what it's saying here. And especially this right here, you have to be like really trained on x-rays. Like, you got to be the radiologist or the pulmonologist or whoever's gotten the extra hours on interpreting x-rays to really be able to look at this and see that there's some definite problems with the pleura themselves. And then the honeycomb doesn't look that obvious on this particular film, but again, we do have a picture that should be coming up later that will be a little bit more clear. So then, as far as like when the patient has now been confirmed to have this type of pneumocanosis, whatever specific type of pneumocanosis it is, when it comes to treatment, all you could say is, you got to find another job, because it's only going to get worse as your body's being still exposed to this. And it may not be that easy just to say, I got to switch professions or switch careers or switch jobs. And then after that, there's, again, nothing we can really do. The damage is there. There is no turning back at all. So even with a good lifestyle, they're trying to live as healthy of a lifestyle as possible. It's still going to be a challenge for them as far as just being short of breath all the time and just not being able to really do much. So if they do want to get better, because they'll be taking like a lot of steroids, they'll be taking a lot of immunosuppressants and all these other things, and that's only going to create more problems if you're taking immunosuppressants. But the only other option they would have is if they qualify for lung transplant. So they have to try to get on a lung transplant list. So now here we have ILDs. Of course, again, this is just kind of like a general, umbrella statement when we say ILDs. And they all have the same problem. There's always going to be this, this fibrosis that's starting to develop from all of this inflammation and healing, and more inflammation and then more healing leaves more scar tissue, and it just kind of builds on itself. And again, what happens when you have this kind of problem? Maybe it was your environment, but not all ILDs are going to be environment related, meaning that a lot of times it's just some kind of autoimmune response that the body will just, for whatever reason, it'll start attacking itself. Like in a case of like rheumatoid arthritis, that's one of those things that it falls into the category of an ILD, but you don't get rheumatoid arthritis from inhaling something in your work environment. Same would go for like sarcoidosis. You don't get sarcoidosis from inhaling dust or powder or whatever it may be. That's why they will just usually say they don't know. They'll just say it's kind of idiopathic, and they don't quite understand why. But there are other ones that they do know specifically, like if you've been in that environment, then they can trace it back to that. But other times with other ILDs, they just won't ever know. But they won't say it's from your work. That part they'll be pretty sure about. Now, as far as the pathophysiology, this is, again, you're thinking about your immunity system, your immune response. If that starts to happen, then you expect all of the things that we've already seen, like with ARDS, to start to happen. And then these granulomas, they may see them or they may not. So they don't really just look for like number two. They just overall, they're looking at just the lung destruction in general to say that this fits the pattern. And then there's the word, again, honeycombing, that will happen. So you got these like little cavities that are going to be created. And on X-ray, if there's a cavity where there's air, then that shows up as dark. And then all of that really thick scar tissue around it is going to show up as white. So if you eat honeycomb cereal, or you eat honeycombs, like a real honeycomb from like a bee, then you know what that looks like. You just have to think about it in terms of X-rays. Wherever there's air or there's like nothing there, that'll show up as black. All right, now number 5, because these are, again, immunity related, there's an immune response, there's going to be a lot of swelling. So the bronchioles are going to be always swollen, for lack of a better word, they're always going to be obstructed. And in which case you have to kind of think about what it is that we can do to try to decrease that swelling, which is usually steroids, and then suppress their immunity system. Signs and symptoms, the kind of classic distress, and then a lot of times this refractory hypoxemia. You give them oxygen, but they're still probably going to be complaining of being short of breath because there's just so much thickening going on, so much fibrosis that's starting to occur. And then the cough, most of these are going to be dry coughs. they're not going to really be productive. But like I said, it just really depends on exactly what the problem is. But in general, you don't really expect them to be coughing up a lot of stuff at all, but they will be coughing up a lot. And then the polycythemia we know is in response to the hypoxemia. The body's just desperately trying to create a situation where there's going to be a better chance of more oxygen being delivered to the cells. And then with more red blood cells means that your blood is now thicker. And as this blood is trying to be circulated throughout the body, the heart's got to work harder to try to get the blood to pass through. And that could lead to some heart failure problems over time. So now diagnosis, of course, they look for that pattern. Sometimes they can see it pretty clearly. Like, you've got these little nodules that look to be nodules or granulomas or just a honeycombing type of pattern that's going on. And then the rest of the general stuff, the history, anybody in the family appears to have these same problems, and they looked into that a little bit further. And then the H&H, the hemoglobin hematocrit, because of the polycythemia, because of the long-standing hypoxemia, that's something that you'd expect. And then when you do a complete PFT test on these types of patients, of course, this is a restrictive problem, so you wouldn't expect them to take a deep breath. So they're going to have very low volumes and capacities, and their flows, like their FEV1, how much they get out in the first second, or their peak expiratory flow rate. Those may be normal, but they may not be. They may be abnormally low. So it can kind of go either way, really. And then the DLCO, the diffusion capacity, is definitely going to be abnormally low. There's no way with that kind of fibrosis that you'd expect the oxygen to be able to get across like it's supposed to. And then as far as if you did an ABG, this is a long-term type of problem. So you'd expect the body to try to compensate for that. And you would expect a fully compensated respiratory acidosis. So they're going to have an elevated bicarb, and that's going to be the compensation for their pH problem and the CO2 problem. So here's what I was saying about this X-ray. Definitely looks to be a little bit more distinctive as far as that honeycombing pattern. So you're looking at your X-ray, you can see a lot of infiltrates for sure, like things that are there that shouldn't be there, fluid mostly related. And it may be the granulomas. And then there's the honeycomb. There's no mistake in this, that this is definitely some kind of ILD. It's like a pulmonary fibrosis or something. All right, now how do you treat these patients? Now, Ms. Smith has been diagnosed with pulmonary fibrosis, and she's always going to be short of breath. So we give her oxygen. She's probably going to need to be on oxygen around the clock. Like when she's at home and she's got to go out and do something, for sure she's going to have to take her oxygen with her. And bronchodilators may be helpful, but maybe not. Only time the bronchodilators are really going to be helpful is if they've got some bronchospasms on top of all of this swelling and inflammation. So really, you shouldn't be thinking like albuterol for someone with pulmonary fibrosis. If anything, they need more steroids and definitely more oxygen. In severe cases, they may have to spend some time on the ventilator until you can get them back somewhat relatively okay. And then of course the steroids and the cytotoxic agents, those are usually like your immunosuppressants that they would have to be taking. And I included this bin over here, the yellow bin, just to make a point that any kind of cytotoxic drug that you give a patient, the leftover drug has to be disposed, not in a red container or red sharps. It's got to be a yellow container or yellow sharps. And for hospitals that give those drugs to, say you got a place that has, a hospital's got its own dedicated cancer floor or cancer area or whatever, they're for sure going to have these yellow disposables. Even the bags are going to be yellow. So that's our focus. I also include that because there's a cytotoxic drug that we give sometimes, and if we have leftovers, we're expected to dispose of it in a yellow container, not a red. So think ribavirin, which is the Virazole. And it's just a side note. We know that we give ribavirin for RSV, but there's always going to be some leftover. They give you, like, the pharmacy will give you a lot of this drug in a container, and it's supposed to be given over so many days. And even at the end of that course, there's probably going to be some leftover, and you just have to search for one of these yellow containers. Ribavirin is given for RSV and is cytotoxic. Plasmapheresis, because a lot of times the ILD is autoimmune and your body's producing all these antibodies. And if you can clean out those antibodies, then they will benefit a lot from that. All right, now smoke inhalation. Smoke inhalation, we know, is problematic in itself if you're inhaling a lot of smoke, but thermal injury is just as bad, if not worse, because if you got someone who was exposed to, someone was in a burning building, for instance, they are probably going to be in the most trouble if their airway ends up getting burned. So that happens in a lot of cases where they get too close to the flame, and then the airway itself ends up getting scorched. And as any tissue that's injured, there's going to be immediate swelling. And now we are thinking about airway patency. So let's just start with the smoke inhalation itself first, because we know there's a lot of stuff that's in smoke, and beyond the other stuff that's not good for the lungs that's in smoke, we got to think about, well, what's going to happen with, all that CO or carbon monoxide that your patient ends up getting exposed to. So in general, when we say that, you've got a victim of a fire and they've been breathing in a lot of this smoke, then all this soot and this acrolein, you can't really see it, but it's ACROLEIN, acrolein. That's something that is definitely going to damage your cells, and it's going to ultimately affect the way that your cells are going to be able to transport sodium across, back and forth. So really what's going to end up happening is it's going to create a situation where, like this acrolein, it can create a situation where your mucus ends up being so thick, it can be almost like cystic fibrosis kind of thick. And then that can create major airway obstruction for you. So now, we're just going to not spend a whole lot of time on the pathophysiology, but we're just going to try to sum it up as far as like the early stage, intermediate stage, and late stage. So what you expect to happen very early on, like in the first 24 hours, Miss Smith, unfortunately, was too close to the flames, and she ended up inhaling the flames. So now there's the inflammation that's going to happen, and we expect that. So there's going to be a lot of inflammation, and then she's going to end up, the body's going to the tissue is going to try to compensate as best as possible. So there's going to be a lot of extra secretions that are going to be created, and she's going to have some bronchospasms on top of that. And overall, that mucociliary escalator or mucociliary ladder is not really going to be working anymore. Or if it does work, it's going to be working very slowly. And that just means more mucus retention. And then around day 2, so they say anywhere from like day 2 to about day 5, almost like nonstop mucus. She's still going to be producing a lot of mucus. Now, we're going to have to assume that she's already been intubated. So these are the things that you're going to still see while she's intubated. So she's going to still have all this mucus going on. And then there's going to be the part where, so all this dark stuff right here, this is, of course, a real airway that was injured. It was a thermal injury. That black right there, that's like old necrotic tissue right there. There's some more here, and just a lot of little other random places right here. There's some right there. This is the sloughing of the TB tree, or the tracheobronchial tree. So as this stuff is starting to peel off, it's going to create mucus plugging. And then if you've got mucus plugging, how are your alveoli going to stay inflated if the air can no longer get to them? So then you're going to have a lot of atelectasis. And then with all the atelectasis, you get consolidation. And essentially, this is like that stage where they're going to be very, very susceptible to getting pneumonia. If not pneumonia, then they're going to have a really bad case of bronchitis. But this is just like the expected thing, and there's not much you can do. I mean, even if you've been suctioning and trying to keep the airway as clear as possible, this was the injury, so this was still going to happen. And depending on just how extensive the injury was, you may have a lot of sloughing of this burned tissue material that's coming on. And then the late stage. Now, in the intermediate stage, this is when you're going to end up with possibly a lot of atelectasis and pneumonia, possibly. But then after the 5th day, this is where you got to really be careful, because they're probably going to they could end up septic very easily at this point. And then also we're thinking about, there's other risk factors that's related. The pulmonary emboli could be something that may happen. And now, this was an injury, so the tissue, the body is trying to heal itself. And that means that if there is some healing, there's going to be scar tissue. So there's the fibrosis that we expect to see. And not only the fibrosis, but there may be, as you see, chronic atelectasis that can't be really fixed. You can do all the hyperinflation and everything else, but it still may be some atelectasis that you're not going to be able to fix. And then the secretions, they may still be a problem, and so forth and so forth. And then notice that it could be so bad because throughout this whole process, there's just been mucus. But then during your late stage, the structural changes that are going on and everything else, now you can end up with mucus that's just trapped in your terminal bronchioles. So like your bronchial walls are now, if we remember, like the different types of bronchiectasis, the different levels of severity. We got the cylindrical, the varicose, and the saccular. And you could very easily end up, depending on just how bad the thermal injury was, you can end up with a really bad case of bronchiectasis. And unfortunately, there's probably not much that can be done about it. It's just like one of those things. The injury happened, and now the body is just going through these different stages here, or the tissues are going through these different stages, and then this is what you're left with. All right, now the signs and symptoms of someone who is a burn victim or smoke inhalation. And now, this was just focusing more on just like the smoke inhalation, but just know that this any kind of like noxious gas that you're breathing into your lungs is going to create the same kind of damage. So obviously, this person here, this patient was a burn victim. They grade, they use a grading system to kind of estimate just what percentage of the body has been burned, and it's hard to know without seeing the entire body and without having an actual chart in front of you to say, is this a 30% or is it a just maybe it's a 10%? But notice that because of the the extensive burning to the chest, to the thorax, if you didn't do this is called an eschorotomy. This is a ventilated patient. This is someone in a burn unit. Now, I never worked in a burn unit, and I never really wanted to work in a burn unit. I mean, if you don't mind the daily skin debridement that has to be done and everything else, all the other very rigorous protocols you have to follow, then, you know, it may be your thing. It's needed to allow the chest to expand and tissues to heal. I say heal better here. So like in this case here, if you didn't do this eschorotomy, you were going to have a hard time ventilating because your ventilator was going to be constantly alarming high pressure. Or, you know, you try to deliver a certain tidal volume and you're not getting a tidal volume because the chest is literally the burned skin. I mean, as the skin starts to try to, especially as it's trying to like heal, it's just not going to really stretch like it's supposed to. So they have to do this. It looks gruesome. And this is the only option that you have if you're going to still try to ventilate this patient. And you may have to check the spell on the eschorotomy because my O's and A's these days, I tell you. So other things, if you're given a clinical simulation type of case where they're saying that the patient has a lot of soot around the nose or around the mouth, then you're going to be thinking the airway may be in trouble because they may have inhaled the flames. If they got that close, maybe, especially if they tell you that the nose hairs or the facial hair has been burned or singed, or the eyebrows have been singed, then you're thinking airway is swelling and and they're in trouble. I may have a hard time, of course, breathing, etc. So all these things are just kind of like obvious if you got burned as far as the outside. But we're mostly concerned about the airway and the internal, like what's going on. Stridor is a classic sign of airway swelling. So upper airways is swelling, you're going to get more stridorous. And hoarseness as well. They're still talking to you and they're hoarse. That would mean that their vocal cords are injured or they're swelling. All right. Now, diagnosis. This is kind of like, why would you need to start with a history? If you got someone is in front of you who looks to be everything that we just described in the previous slide, there's the soot, there's the skin is red, there's the eyebrows, the eyebrows have been burned off or singed off, then it'll be pretty obvious. But this is smoke inhalation thermal injuries because remember, what if it's not that obvious? You have someone who maybe they were breathing in some other chemical that caused some injury to the airway, some kind of injury, or if they were breathing in hot gas. Steam, as we know, is extremely hot. So if you or say accidentally was near something and there's a pipe or really a hot pipe or hot water pipe or something, and then it burst, and then you got a face full of steam, and you breathe in the steam, then that's definitely going to be a problem for you. That's worse than just breathing the actual flames from a fire, really. And one other thing about breathing in noxious stuff, the cleaning supplies that you use, they always give you a warning. Never mix these things together. People feel that if they mix them together, they're going to be even better as far as cleaning, but you're just setting yourself up for a problem. If you're wearing a mask, sometimes those chemicals are so strong they can literally permeate through the mask, and then you're going to be possibly at risk. Now, this is a situation that happened at one of our clinical sites back in LA. A patient was admitted to the hospital, and she was lucky. She didn't end up in ICU. She just got admitted to the floor because what she had done was she told the staff that she had a dirty floor and she really wanted to get it clean. So she poured a lot of like whatever it was that she had. She poured that on the floor, and she had something else, and she poured that on top of that, and she took something else and poured it on top of that. And she said she wanted to let it sit on the floor and soak in. So then she took a nap. So the whole time that she was napping, I don't know how she fell asleep with those kind of fumes that were being generated, but she napped, and then the whole time she was breathing in all these fumes that were coming from all these different things that she mixed together on the floor. So then she ended up they did end up diagnosing her with, if I remember, they diagnosed her, I think, with BOOP, if I'm mistaken, because I had to ask the student who I was visiting exactly what was going on, and so all I remember is that they were saying she was lucky. So really, she probably just had like a pneumonitis kind of thing going on. Now, the diagnosis, of course, if you obviously see that there's signs of injury, and then the sputum, take note of the sputum in the clinical simulation. If they give you a situation where, say that you click sputum, or you click to check sputum or something like that, if they tell you that the sputum is carbonaceous, that's the soot. That's black soot from the smoke. Carbon is going to be one of those byproducts that happens from combustion or incomplete combustion. Like in the case of a fire, as a fire is burning, it needs oxygen to burn, but then it's not getting enough oxygen all the time. And so if it doesn't get enough oxygen as it's burning, it's producing, in addition to all them other millions of bad chemicals that it's producing just plain old carbon as well. And that's the soot that ends up settling. And then, of course, they can go into the airway and look to see. They can do a bronchoscopy. If you didn't have a bronchoscopy, a shortcut would be, if you had a laryngoscope and a blade, you could do that. Go into the airway and look around and see what you can see. X-ray may not show you any problem in the beginning stage. And I remember the beginning stage, like somewhere around like the first 24 hours, X-ray is not really going to show any kind of serious problems. It's going to be, they're just going to have a lot more mucus. There may be some, of course, reddening going on inside of the actual airway, but nothing really as far as X-ray. And then as you get into like around the day 2, around 5 days or so, that's when, they can start to have like the pneumonia type of, or bronchitis kind of thing going on. And then as they're going into their late stage, that's when they could end up with the worst X-ray. So that's when you could see all of that, all those infiltrates, maybe going into our hearts is what this is saying in that last stage of this injury. So then treatment, of course, we have to do a lot of suctioning to try to keep that airway as patent as possible, but they're just like producing it like nonstop. and they may have to go in and do a bronch, a therapeutic bronch, to help with keeping the airway patent. And then for someone who got exposed to a lot of carbon monoxide, we know that hyperbaric oxygen is the way to go. If you're wanting to try to get the half-life of that carbon monoxide down to like a mere minutes versus like hours, then you're going to need to place them in one of these chambers. Now, she is inside of the hyperbaric chamber. And here's, of course, this is a ventilator, this is Cervo I. Is it the U? That's the I. So this is a Cervo I. Don't know exactly what she's doing. She's got the cuff manometer, like the ET2 cuff manometer. She's got that connected to the pilot balloon. And she's got her hand on the bulb that you squeeze when you're trying to. This looks like the setup you have for an A line or an arterial line, but I don't quite, because it got cut off and everything. I don't quite know what she's doing exactly, but it's something that's going to be related to cuff management, I imagine. Because when you're inside of one of these chambers, this simulates you're underwater, like so many feet underwater, like 2 atmospheres below, or maybe 3 atmospheres below the water surface level, which means that barometric pressure is really, really, really high. That's going to have an effect on that cuff. So you're going to have to, of course, make sure that you manage your cuff pressure appropriately, just like if you were going up in the air, like air transport, and the cabin isn't pressurized, then you have to do the same thing. You have to alter your cuff pressure as you need to. And of course, analgesics, because I mean, you can imagine the pain that's associated with those really, really bad burns. And again, more of the same as far as like trying to keep their airway as clear as possible. And then again, don't think bronchodilator unless they obviously are wheezing, and it may just be that they've got some serious bronchospasms going on. Now, prophylactic anticoagulant, when you work in a burn center, RTs will nebulize heparin. So you're going to have to you're not only just giving bronchodilator treatments as needed to these burn victims, but you're also nebulizing heparin to help with all those clots that are going to start to develop. Because remember, around that intermediate stage, especially towards the late stage, they're at high risk of developing pulmonary emboli. So they have to be proactive on that. And of course, not many burn victims are going to not be intubated. Pretty much the majority, especially the extensive burn victims, they're going to have to be on the ventilator. Okay. I wrote nebulizer. Oh my goodness. It's break time anyway. Now, we'll pick up from here after the break. Okay, so we're back. And that's a good point, Kevin, that there used to be asbestos everywhere. I mean, especially like with the brake pads. And and the older buildings, a lot of them, they just had to spend the money to get the flooring redone, ripped up the floors, the walls to get all that stuff out. And it's so funny that the first place I was working, the first place I was teaching, their physical therapy program or physical therapy assistant program, the room that they use for their skills practice, like their little gym. I don't know how, but somehow they found out that there was still some asbestos in that floor, and who knows how long that's been. I mean, how long people have been exposed to that. I mean, students come and go, so they're not going to be at that great of a risk. But I guess it was more for the instructors. If you had any of those PT instructors who had been in that gym all the time for years and years, they're the ones that were mostly at risk. But once they did find out that the asbestos was still there, he had a popcorn ceiling as well. Exactly. Once they found out, they had to just literally they had to close that little gym down for a while and rip all that stuff out and get rid of it. And then when you think about it, just your people in the environment in general are going to be exposed. I mean, when you think about a high pollution area, pollution is a combination of a lot of stuff we know. It's not just the obvious. It's not just the smoke that's coming from the fires, and it's not the exhaust that's coming from the cars. Think about a city that's got a lot of commuters, people that are just like commuting to work every day, and it's busy freeways all the time. There's a lot of stop and go traffic. So a lot of your pollution is brake dust from the brakes themselves. So you gotta be aware that if they didn't make that decision to change the way that they did some things as far as like manufacturing, especially like say with the brake pads, we were always gonna be more exposed in those more busy areas in those cities that have more people. Okay. And yeah, definitely popcorn ceiling. Do not ever buy a house or rent a place that still has that popcorn ceiling. I mean, they shouldn't be allowed to still rent out and buy or sell places like that anyway. That stuff has to go unless you're not concerned about your health or your family's health. Now, lung abscesses, not much really going on with lung abscesses, except for the fact that we know that it's usually something that you aspirate it, and that's what's causing the actual problem. And you end up with just an area where there's a bunch of pus, or you got a lot of tissue that's breaking down, and then it kind of like the lung, I guess, is trying to like wall off that area, and so you end up with like they call it like this pyogenic membrane, and then all the nasty stuff is on the inside of it. So we look at different things like nursing home patients are definitely at most risk of having a lung abscess because they're the ones that sometimes end up aspirating a lot. So your aspiration pneumonia, Klebsiella is an organism that they find that's associated with this a lot, staph, and definitely any anaerobe. Any anaerobe is going to be one of the things they find being behind this. In a case of someone who's got really bad teeth and there's a lot of dental decay, if those organisms find their way into the bloodstream and then they make their way to the lung, then you could possibly end up seeing this lung abscess develop. Now, as far as the pathophysiology, especially like in the case of an aspiration pneumonia, you're probably going to be treated for pneumonia. And and then what happens in pneumonia is, again, this is all white blood cells are going to be responding, and then more white blood cells are going to be responding, and then you're going to end up with all this like swelling that's going on, and then you end up with like atelectasis, consolidation, and then in the healing process, and as there's more fibrin and all this other stuff, then you're going to end up with the cavity formation going on. So we start off with, as far as, let's just look at what's going on with that cavity. So you got this one big cavity, and there's this pyogenic membrane that's surrounding that cavity. And then you're going to end up with a fistula in most cases, and possibly a really bad case of empyema as well, because this is all nasty stuff usually. Like it's mostly like the anaerobes that are behind it, mostly. And then you're going to have more atelectasis to be dealing with, and then more secretions. And so it's just going to be one of those cases where you've got to get to the bottom of the problem and then go from there. So signs and symptoms, and first line is distress. Everything is up. Breath sounds can go anywhere from coarse crackles to just coarse rails, maybe. And rhonchi is just one of the words that some places will still use to describe coarse rails that will usually clear. If you can get them to cough, a coarse rail or rhonchi or rhoncus should clear. And they may complain of chest pain, and they may not be coughing anything in the beginning, but they may be coughing up a lot of bloody stuff. And for sure, if it's an anaerobic organism that's responsible, it's going to smell. Anything that smells bad, it's the anaerobes that are causing it to smell like that. So it's the gas that they're emitting. So like when you think about an animal on the side of the freeway that's decaying, it's all of those anaerobic bacteria that are emitting all of that noxious gas that's creating that smell. And as we know, our friend E. coli is an anaerobe. So you go number 2, and that's what you're smelling. You're smelling the E. coli, more or less. And if it's an aerobic organism, it usually doesn't have the stuff that they're coughing up. Usually isn't going to smell that bad, and it usually takes on like a greenish kind of color. We mostly associate green with Pseudomonas, mostly, but that's not in stone. That's not like always expect Pseudomonas or infection or agent organism to be responsible for causing green sputum. That's not, we can't really say that, but that's just one of the common findings. Now, how do they diagnose this? Of course, start with the history, do an evaluation, and then look at the sputum. And again, if it's really foul-looking sputum, it's brown, it stinks really badly, and then you see this on X-ray, then you know what you're dealing with. This is definitely not pneumonia, but it's actually a lung abscess instead. And on the X-ray, your cavity, so you should be able to distinguish it, and it should be kind of standing out pretty noticeably from the rest of the lung. And also this area right here, all the white that's surrounding, this is the actual calcification that takes place. So that should show up just again as more white. And in some cases, there may be a pleural effusion or an empyema that will develop as well. So how do you treat? Well, for their shortness of breath, O2 would help, and get them to cough as much as possible to try to help clear away that stuff, or use any kind of hyperinflation like incentive spirometry. PEP therapy or any of those other methods to try to help them with being able to take a deep enough breath so they can clear away this stuff. The antibiotics would, of course, be obvious for if you know that it is some kind of bacterial agent that's behind it. It usually is some kind of bacteria. Then it would have to go in and drain this stuff because, again, the lung is just kind of walled it off. And if you didn't go in and drain it, it's just not, that stuff is not really going to go anywhere. And in really bad cases, they'd have to go in and cut it out. So they have to kind of like do a resection of it if it's like really, really, really necrotic and bad. And it's not really responding to all of your treatment. So then we get into the fungal diseases. So fungal diseases, you can end up with a fungal type of pneumonia. As we know, there's like bacteria, viruses, fungi, and in some rare cases, an actual parasite that could lead to a pneumonia. But a fungal disease is going to be a little bit more than just that. So we're looking at all of these different little spores that are always floating around in the air because they're always somewhere inside your house. They're on the outside, and it depends on your region of where you are. So like in the case of like, histoplasmosis versus coccidioidomycosis or valley fever, and et cetera, et cetera. So then this map right here is just to kind of show you a breakdown of mostly where you would find the concentrations of these different types of spores and the people who end up getting sick as a result. Now, of course, not everybody's going to get sick because it all depends on your immune system or your immunity system. And we are, of course, we're mostly like in this area, like in the San Joaquin Valley area, we're going to expect to see a lot of the coccidioids, which is, of course, represented very clearly in our region here. All right, so what happens with this? So you're breathing in these spores, and then they get to your lungs, and they start to set up camp in your lungs. They start to germinate. Now, if you've got a good immune response, then your white blood cells will usually take care of it, and it'll usually wipe it out. But if it's overwhelming your white blood cell or your immunity system, then you're not going to do so well. So this right here is just going to continue on, you're not doing that well. So then you end up with fluid that's now, again, leaking out of the capillaries and getting absorbed into the alveoli, and there's going to be a lot of swelling going on. Then you're going to get the atelectasis, consolidation, and then your AC membrane is going to be affected. And then you can start to end up with these little granulomas. They call them like tubercles or granulomas that are going to start to deform. And then you get the calcification. So this is like the worst case kind of a situation. Again, if you're healthy, you would have been fine at step 2. So then this right here just kind of represents what's happening because, again, these spores are everywhere. You never know where they're going to be mostly. Can't see them. Mostly they're pretty microscopic. And starting with this right here, your bird droppings. Now, birds are going to be carriers of like the histoplasmosis. They're going to be the main carriers. Bat droppings is another source of the histoplasmosis. The what is it called? Guano, the bat droppings in certain areas where there's a lot of caves and there's a lot of bats. And let's say, okay, the birds are doing their business. There's bird droppings in the dirt, and then those little organisms are in the bird droppings. And then the birds are playing around in the dirt, possibly. Maybe they're kind of like skirting around in the dirt, or the wind is blowing and it's causing some dust to kind of like to start to form. And then here's the guy jogging by and he inhales and then it just kind of goes from there. As you know, your immunity system will start to respond and and then he ends up with a mild pneumonitis and then it just goes from there. So as you see, similar to like ARDS, this could affect more than just your lungs. It could be all of your organs that are going to be affected because once these organisms find their way in your bloodstream, they're now able to go anywhere that they want in the body. So it's kind of like their transport, and usually their goal. These invading organisms are usually they're trying to survive. They want to multiply and they want to take over. So they're going to want to go everywhere they can possibly go to do that. Now, signs and symptoms, like in the case of valley fever, a lot of times it's not that bad. I mean, they may feel a little bit, you know, like they've got a little cold or something. It's not that serious. And then they may be fine because again, the body may be able to fight it off. But then in other cases, they're going to just go in, they're going to deteriorate. So they're going to go into more distress and they may cough up a lot of stuff. As you see, it could be blood tinged in some cases. And they may complain of being like, having like chest pain. So then, because they may just be given antibiotics, like take some of these, like take this penicillin, amoxicillin, or whatever, for a couple of weeks, and then see how it goes. And if they aren't getting any better, then they'd have to maybe suspect something like valley fever, especially like say you live in the San Joaquin Valley area. And these spores, just mind you, they travel. I mean, they really, really travel. There was a case where I forget the year, but I don't know exactly how far Bakersfield is from the center of the San Joaquin Valley, like the what's that area called in the very center? Vidalia, Visalia. Like in that area. I don't know exactly how far. I know it's not that far, but there was a windstorm one year, and the cases of valley fever in Bakersfield went way up after that windstorm, and they felt that that was the perfect vehicle that these spores needed to be transported from the center of the San Joaquin Valley all the way up to Bakersfield. Now, as far as the diagnosis, they could do a CNS or a sputum culture, and they could to check to see what organisms that might be growing based on what they look like, size, and how many, and et cetera. Or they can just, of course, look for the blood cultures as well, and then the X-ray. Now, this X-ray, again, you wouldn't be given this X-ray and expected to know what is this exactly, what kind of problem is this, because all you could see that there's definitely a problem. There's a lot of like what looks to be infiltrates. There's more white for sure. So there's a lot of like things that are going on here that isn't normal. And it's just one of those things where if they're suspecting that it's some type of fungal type of infection, with everything else that they've collected, they've done the exam, they've looked at the cultures, they've looked at everything else, and then you look at the X-ray, and it kind of like brings it home and say like, well, this definitely has got to be a case of some kind of fungal infection. Now, the fungal disease, as you know, if they give them antibiotics because they think it's just like a pneumonia type of a situation, they're not going to respond to those antibiotics. So you have to treat the fungus with an antifungal. And the drug of choice still is the amphotericin B. Amphotericin B is that class of antibiotic or that class of antifungal, I guess you can say, that will pretty much wipe out any of those fungi. Or they can do like the a, tri- a triconazole, a triconazole or fluconazole. Uh, what is the actual trade name for these? Let me try to remember. Antifungal, and it escapes me right now. But these are the drugs that they would have to give if they're going to expect any kind of response. And of course, O2 for the shortness of breath that they're going to be experiencing, and anything else, helping them with maintaining patent airway, like keep them coughing if they're productive and things like that. Now, TB, I mean, of course, we have to always get tested for TB if we're working in healthcare because there's always the potential of exposure. And of course, for some people, if you grew up in another country, you may have already been exposed to TB, and so the standard or traditional screening methods are going to have to be adapt. They have to modify them for that reason. So just in general, we know that TB is the mycobacterium, and you're not going to get it any way else except for inhaling it from someone who's an actual active carrier. I mean, who's a carrier, but who's in an active state of TB. So that means that if you have someone in the hospital who's positive for TB, you have to place them in an airborne type of precaution, either airborne or droplet. Sometimes places will combine the two and just say it's like airborne precaution, which also will cover droplets. And the difference, of course, that we know airborne organisms, they can hang around for a pretty long time in the air versus the droplets. If, say, the patient coughs or sneezes, then it's going to only hang out in the air for just a second or two before it ends up hitting the floor or hits the wall. And then this microscope, this actual scan here, electron scan of the organism, looks like flaming hot Cheetos to me, but this is the actual tubercle type of shape that you'd expect to see, or the bacillus shape that you'd expect to see, not the coccoidal type of shape that you'd expect to see with the other fungi, but more of a bacillus type of shape. Now, as far as the COVID thing. So again, this is all new territory, and they were just really trying to figure this out as far as, is this really going to be droplet? Is it going to be airborne? And again, places that I've worked, there was always like a debate, it seemed, between, they are. That's the thing. A lot of places, there's always a debate, like, is this truly going to be a case where we got to isolate them for strictly airborne, or is it going to be droplet? But I think a lot of places felt that if you kind of like combined it, then they'll take care of both. Your approach will be the same as far as how you're going to protect yourself. You're going to need to ensure that, you got on the proper protection. But I think it really came down to, do you really need to do the N95, or can you just do a surgical mask and be okay? Now, what happens in TB? So you've got someone who has active TB and they're spreading it unknowingly. And then you inhale the organism. So then, white blood cells, they go into action, and they're not going to be able to just attack the organism and just like kill it. They're going to end up having to try to like isolate that area, kind of similar to like a lung abscess where you got that pyogenic membrane, kind of a walled off situation. But as they continue to try to deal with these organisms, then that's when you get this disgusting looking granuloma that will develop. And this is a real, true person's lung who had active TB. And then there could be a lot of like once the area starts to try to heal, then you get like scar tissue that's like fibrous material. It gets more, more fibrous and more fibrous. And then that's the problem. Now you've got this mycobacterium that's just literally protected inside of this little cavity, which means that anytime you could end up right back into like a full blown, you're actively experiencing TB and you're contagious and you're spreading it to someone else versus when you're in an inactive state. So again, this is just a visual of, you've got someone who is unknowingly getting exposed to the TB, and then once it's in his lungs, then your white blood cells, they take over, and then what ends up happening is they are having a hard time dealing with this mycobacterium. So then you've got this whole granuloma that's going to start to develop. And then it just gets more disgusting. And then that's pretty much that. So once that has happened, it's going to always be there with you. It's just all depends on the state that you're in, as far as are you actively dealing with it or is it not active? So the signs and symptoms, more of the same, the distress, they may complain of being like they're having some chest pain with it. It could be affecting their oxygenation. So they could, of course, have some cyanosis that's related to that, the bloody sputum, but then a night sweat. So unexplained night sweats with unexplained weight loss. Those are usually red flags. Now, night sweats could be some other metabolic thing going on, that could be causing your patient to have to wake up in like cold sweat kind of thing. But it's really the combination of, you're losing weight, you had the night sweats, you're coughing up some bloody stuff, and you may have a fever or may not. So that's not something they really look for in TB. And then as far as diagnosis, again, we all know that anybody who works in healthcare who's coming into direct contact with different patients who you may not know their complete history, especially when they come into the ER, you got to get your TB testing done on a regular basis. Now, some hospitals still do the old skin test, or the mantle tuberculin skin test, as they call it. And other hospitals have switched over and just pretty much they're going to do the blood test, the quantiferin type of test, which is considered like a gold standard. Now, the problem with still using the old fashioned skin test, where they inject a little bit of the weakened mycobacterium into your skin, they create a little wheal. This is called a wheal here. Anytime you inject medication underneath the skin, you expect to create a wheal. Is it an E on wheel? Wheel, W-H-E-A-L? Or maybe there's an E, maybe there's not. I don't know. Either way, look at how this person is measuring, because your standards will say that if the wheel ends up being more than like 2 centimeters and length, or more than 3 centimeters in length, then that would mean positive. This person has been exposed to TB, and this is the immune response that they get. And the only problem is this is very subjective. Like, where do you start measuring exactly? And you probably will say, maybe this is the starting point and I start measuring from here. But then the next person may say, no, I should push the ruler back a little bit further and then start measuring. So as you see, it's going to be problematic depending on who's doing the reading. And then how many places are really going to be measuring? Most of the time, when I've had the skin test done, they would just literally take their finger and run it across to feel if there's anything. And then they would say that's fine. And then of course, if they did see something, a little area reddening, they still didn't take out a ruler and measure it. They just kind of like eyeballed it and say, okay, that looks to be fine. At least with the quantiferin test, there's not any room for error. There's not that kind of error as far as who measured how. And then one other thing about this skin test, this can be deceiving. So let's say that your guidelines will say that anybody who after the skin test end up with a reaction that's more than 2 centimeters, then they're definitely somebody who's been exposed to TB, and we need to get them started on medication. What about the cancer patient? What if the cancer patient has been exposed to TB? That cancer patient is not going to have enough of an immune response to even give you that 2 centimeter. So that's something you got to keep in mind, that unless you do the blood test, you can't always be guaranteed that the skin test is going to show you the right results, because it will come down to a lot of times the patient's immune response. Do they have the ability to respond appropriately? Do they have enough white blood cells to respond appropriately? Okay, but it's interesting to just see who is still doing the skin test out there and who has just said, forget that, and let's just go with the blood tests. TB on x-ray, so lots of, again, white. So you've got a lot of opacity that's going on. And mostly you're looking for like those little walled off cavities. You're looking for, like in this case, you've got it on both lungs, and that's pretty bad. And the left one looks to be a little bit worse than the right lung. So that's all that calcification that's going on. And inside, that's where the actual mycobacterium is. And that's the granulomas that have developed. And then you're left with this permanent scarring, which is why this is a restrictive lung problem. And now, how do we treat these patients? Well, it's going to take a lot of treatment. So as you see, this INH and rifampin, they may have to do like 6 months of this, or they may have to do like 9 months of this. And they try not to prescribe the really, really long treatment plan for most patients, because it takes a lot of discipline. Most people are just going to get over it. They're going to be like, I'm tired of taking this every day, this many times a day. And for how many more months I got to do this? So they try to always do like the lesser, but it's still a lot of months that you have to take these drugs in order for you to get any kind of like benefit from it. So there's another one, I keep forgetting it. So there's like INH, rifampin, and there's one more that they will sometimes prescribe for TB patients. My mind's a blank. So, but these are the major two right here, the INH and rifampin, for sure. And then O2 for their shortness of breath and help them with mobilizing secretions. And then your negative pressure rooms. Now, the hospitals, they have to ensure that if you've got a dedicated negative pressure room, it has to satisfy at least some basic requirements. The basic requirements is TB isolation rooms. Well, really, not just necessarily TB, but anything that's going to require a negative flow room. So TB isolation rooms should have the ability to perform at least 12 air changes per hour. Now, I think the WHO is mostly behind this. This is for everybody around the world. I mean, all the hospitals around the world. Some places will say anywhere from 6 to 12 air changes an hour would be satisfactory, but 12 is like the common number, no matter what. And what that means is a standard negative flow room will draw in air from the hall. So there may be another antecubital room before you get to the room. And even that room has to have the ability to do maybe 12 air changes an hour, maybe 10 air changes an hour. But let's just say that this one doesn't have that antecubital room. It's just that if you open the door, you're going straight out into the hallway. So with the door closed, it's pulling in the air from the hall. And then there's another, they've got like a HEPA filter set up in here, which could be helpful. But if they don't have a HEPA filter unit set up inside of the room, there's definitely an industry grade HEPA filter in the HVAC system. So as the air is being pulled in from the hallway, it's going to leave the room, and before it gets dumped down into the parking lot somewhere, it's going to go through this really, really industrial grade type of HEPA filter. And then people that are on the outside should be okay as far as, this air that's being dumped out into the outside. And air changes just means that whatever the size of this room is, like all of the area inside of the room, you have to have the ability for that air to be replaced 12 times with fresh air every hour. And that way you can kind of cut down on the potential for if this is someone who's definitely an active TB, to protect anybody who's in the room from these organisms that are just floating around in the room, possibly, or they're the droplets are in the air, or whatever the case is. But that's how most negative rooms are going to be set up in the hospitals. You won't see anything on the outside of the room that says 12 air changes per hour. You're probably just going to see a control unit that you could, with the right key, insert it. You can switch it from a positive flow room to a negative flow room. And I don't know of any application where you need to have these rooms set up to be pushing air out into the hallway. If anything, it's always negative flow where you're pulling in the air. So that way you can exchange it for what's on the inside of the room. Okay, and for this section here, if you got somebody who's cleaning a chicken coop, what could they possibly end up with? Right, so it's the histoplasmosis, and remember, it's your bird dropping, so it doesn't matter what kind of bird we're talking about. Bird is a bird, and if they are pooping, then this organism is potentially in that poop, and then you could accidentally or be unaware and get exposed to it. And again, also with bat droppings, or bat guano, as it's called. And how would a patient with a pulmonary fungal disease who later ends up with cor pulmonale, how would they present? Okay. So you have a fungal disease, and then later on you end up with cor pulmonale. So the key here is the cor pulmonale, which is the right side of heart failure. And if the right side of the heart is failing, then things are backing up. So the blood that's trying to return from the head, it's trying to return back to the right side of the heart through the jugular veins. But if the right side is not working properly, as we know, things are going to back up. So then that's when you would start to see those neck veins starting to pop out, and that would be your JVD, or jugular vein distension. So that's something that you just commonly would expect to see with right side of heart failure, is the JVD. And skin turgor, this is literally, you would have to pinch the skin and pull on it. So if you get someone who's really hydrated, you pinch their skin and you try to pull it from their arm, like you're pinching the arm and you try to pull the skin away, it's not going to be that easy. It's going to be, the skin is going to feel pretty plump, and that will be a good sign of good hydration. Now, compare that with a little patient who's in a nursing home, and where they end up with being practically just skin and bone, and they end up being really, really dehydrated in a lot of cases. Their skin turgor is going to be poor. You could literally like pinch their skin and almost pull it completely away from their bone or from their arm. So that's a really quick skin assessment that can be done at the bedside. And again, that wouldn't have anything to do with right side of heart failure. And then the asymmetry with the chest expansion, that wouldn't have anything to do with cor pulmonale and the wheezes. You would expect to have that either. So really, this question was more about the right side of heart failure than anything else. It wasn't really asking about the fungal disease portion of it. Now, which X-ray? So you got someone who's in end-stage ILD. Okay, so yeah, this is that classic kind of like a honeycomb type of appearance that they would end up having. There's like so much scarring and and so much thickening that's going on that it takes on that almost like pattern. Early stage of lung abscess would will look almost like, which one of these? Yeah, they'll treat it like pneumonia because it'll look like pneumonia. But then they'll realize later that it really is a pneumonia. True or false? Okay, this is true. This is like the concern is when they're going to really start to end up with some mucus plugging during that intermediary stage. So all of these except. So the things that we expect to see with someone who has TB, they would have unexplainable weight loss. They would have like the night sweats, they would have the weight loss, they would have the possibly bloody sputum. They may have some blood streaking in his sputum. And the fever may not be there. So it may be a mild fever or it may not be a fever. So that's just like one of the things, don't expect it, or in other words, don't bank on them having a fever if they've got active TB, because they may not, but they will have all those other signs and symptoms going on. They may also be complaining of some chest pain. All right, and then how are these spores usually spread? Whether it's a coccidioid or histoplasmosis, aspergillus, or whatever. How are they usually spread? Okay, so the thing with all of these fungal organisms, they reproduce by releasing these spores into the air. So that's how they make it. That's how they move on to the next place and set up shop and grow. So like in the case of your lungs, if you inhale them, they start to try to grow. So in other words, they're trying to create more mold. Like, think of it like mushrooms. You know how mushrooms will just kind of sprout up anywhere, everywhere, anywhere the wind takes them, the spores, that is. So if you inhale them, they try to do the same thing. They're going to they start to germinate. But again, if you're strong and healthy, your immunity system will put a stop to that pretty quickly and just take care of them before anything happens. But if you're not doing that well, or your system is overwhelmed for whatever reason, then that's when you start to end up with the problems of, having the fungal disease, the lung disease. Okay, so that's the last of our restrictive diseases. Again, these were all restricted for whatever reason, and these all were mostly focused on the lung itself, undergoing some kind of immune response, and then that creates a lot of inflammation and swelling. Then you get a lot of fluid shifting, you get a lot of thickening of the AC membrane, and then you've got a long-term type of problem that isn't going to be easily fixed anymore. Now, so tomorrow all we have is the final. Yes, all we have is the final tomorrow, and the research project is due by, 1 o'clock tomorrow. And that means that I guess I need to activate the end of course. It feels like a curse sometimes. The end of course survey. I'm going to have to go ahead and activate that. And so that means that we're done. This is it. This is all the material that we have. And so now you're in a good position to go into term 6 and get prepared for the board exam. So no more new concepts. So if anything, as they're helping you to review in term 6, it'll be to reinforce some things, like some things you may not have quite understood, and then you'll get a chance to go back and review it some more. And especially with the hands-on stuff, like with the little quick mini labs that we've had, they're going to have to make sure. And I think it's the main reason why he wants you there that first week or two on campus, so that way you get more time to be hands-on and to do the ventilator management. And he's going to give you some case studies to work on in groups, so you're going to be able to practice literally going from whatever's being described in the case to now translating that to, here are the event settings that we need to come up with, and these are the changes that we need to make. These are the changes that we need to make. So he's trying to simulate like a real at the bedside kind of thing before you actually have to go off to the hospital and then be in a much better position. So the last term, or at least the current term 6, they said that helped tremendously for them to be able to just kind of spend that first week or so. But for them, it was more than a week or so, because it took a while before the clinical site started to reopen. But just the fact that they were going in there and they were able to practice it and practice it and practice it, then it made it so much better. And they felt more confident and comfortable when they did go to their clinical sites. And even their clinical preceptors made those comments, like they didn't expect them to be that prepared, given that, everything had started to shut down and nobody was taking students anymore. So the fact that they had been doing such good simulations in that lab, it made a world of a difference. So that's where we are now. And I'll be online for the most part still with Teams, but I got to go and get my last COVID shot. And during that time, I'm not going to be online, but then I'll check back in to see if you have any questions. And if not, I'll just see you all in the morning for the final. So use the rest of the day definitely to get ready, finish up your projects and review whatever you need to do. There is a practice quiz that's covering like the obstructive and restrictive diseases that I posted or uploaded last night or yesterday. So you can take a look at that as well to help you with studying. Okay, so I will see you all in the morning. That's all we have for today.